let's move to our next portion, which is what I call placing the perfect central line, sponsored by Shyam and Harman. All right, Shyam, ready for this?
Let's do it.
You're going to start, of course, by draping the patient. So let's get your fenestrated drape and have you put it on. So you peel your fenestration off, right? And again, remember, you already sort of know exactly where to place it owing to that lidocaine pearl we talked about earlier. You flip it over. If you flip it over, there are a couple of arrows that show which side goes towards the head and which side goes to the foot. Keep that in mind. That's superbly important. You saw Shyam do this sort of fold ninja move. That's so that you've got some adequate pliability and you don't contaminate yourself. You plop it down, open one side, and then the other horizontally, watching your kit so you don't plop anything off. And then there's a part that opens towards you. And there's a part that goes away from you. Now, please note that these drapes, just like many of the kits, are also sometimes different in the sense that they don't cover the whole body. You need to have complete and full barrier body covering. So if you need a added additional full body drape, go grab it, use it. All right, Shyam, all set?
All set.
All right, perfect. So at this point, because I'm anal, I usually grab one other ChloraPrep that usually comes in the kit and just take your fenestrated area of skin that's available and clean it off again. And as we all learn in surgery medical school 101, blue, okay, not blue, not okay. Know it yourself and tell everyone else in the room that as well. You cannot touch the blue. All right. All right. So then we're gonna drape our ultrasound probe.
So I like to use my one-person technique for this.
All right, show off.
The ultrasound already has some jelly on it, and I have it standing up and kind of sticking out of the machine. So I got my ultrasound probe, and as long as I don't touch anything else, I'm sterile. So I just take this, reach over, grab my probe, and drape the probe. And I've already got some jelly on the inside, and I can just bring this over like this.
And perfect. Well, Shyam's a pro at it. This is where attending usually leaks troponin. Okay, so now that the probe is covered, you take a little bit of ultrasound jelly, put it on the neck. Not a lot. You don't want to make your feel too goopy and unusable. You put the rest of it to the side. And
my technique with the rest of it is I actually find a spot away from whatever I'm doing. And I just kind of put a little extra here just so I have it available and I don't have to reach for this later.
Superb. All right. So then let's grab your introducer needle and let's get started. So the introducer needle here that Shyam is using has a specific barrel on the syringe. And not every kit, again, has this. But Shyam, you want to tell us about the blue barrel?
Yeah. So this is a little bit of an interesting syringe itself. Not only can you just use it like a conventional syringe, but you can actually feed a wire through the back end here. There's a little hole. This has a name. I forgot what it was, but it's got a specific name. You can feed the wire through the back here, and it'll come out through the end of your needle here.
So if you don't have that particular syringe subtype, and Shyam, to be honest with you, I forget the name too, but it's probably better that we leave it non-proprietary. But the idea is that in your vasoplegic, superbly volume depleted patient who's having a lot of respiraphasic variation of your actual vessel, the idea is that this prevents one step of you actually disconnecting the syringe from the introducer needle, and so that your patient doesn't go, and there goes your venous air embolism, right? Now, there's a downside to that, right? Like you have to have even more dexterity so that you can drop the needle angle and pass your wire, but Shyam will show you that. If you don't have it, doesn't mean you can't do it. You just have to be a little more careful. So know your kit and use it to your strength. You've found your target. You isolate your ultrasound probe and immobilize it by the pinky technique, where the hand that's using the ultrasound has the pinky to immobilize that hand. You grab your introducer needle. And Sham, can you show us that perfect technique once again of how you hold the needle?
Yeah, so 2 fingers under the base of the syringe and a thumb on the flange allows you to have full range of motion of your wrist. So you can kind of do this from any angle that you need to.
Perfect, right? You have the probe, you go about 45 degrees geometric setup behind. So if your vessel's about 1.5 centimeters deep, you go 1.5 centimeters back, align the needle to the middle of the probe. I generally look down and make sure I've broken skin. And as soon as I've broken skin, I look up. And the rest of it is looking at the ultrasound, right? The ultrasound alone. So you break skin.
Okay, broke skin.
Right, look up. And from this point on, until you actually can visualize the tip of the needle inside the blood vessel, you don't need to look down again, right? So you get in, you follow your needle down, you try and enter at the center of the blood vessel, you get flash, and then that's when you put the ultrasound probe down. Take the pinky on the hand that had the ultrasound, immobilize it on the mandible or somewhere on the patient's neck, disconnect the syringe from the actual needle. And of course, if you're using that blue syringe that you can feed the guide wire in, then of course you're not. And at this point, your introducer needle has gone in at a fairly acute angle, about 30 to 45 degrees, like I said, with the ultrasound probe orientation. But then when you're passing the guide wire, you drop your angle. Drop your angle fairly flat so that your J-tip has a nice smooth passage in, right? And you're going to want to go to about 15 to 20 centimeters. Make sure there's no resistance. Take out your sleeve. Secure your guide wire like Sham is holding. Remove your needle. Secure your needle. Make sure your guide wire isn't jumping around. And this is where you pick up the ultrasound probe again. And you confirm the existence of your wire in 2 planes. Short axis, compress it up and down, and long axis. Fan it back and forth, and make sure you can see the entire guide wire not just enter the blood vessel, but make sure it's actually not also backwalled into an artery. Once we feel good about it, we're going to grab our handy dandy scalpel. And again, open it to all the way and take either half depth, full depth, depending on the patient. And now you have to feel sort of secure about this because you know, right? When you've taken a look with the ultrasound, you know from the level of the skin to the level of the vessel. In the thinnest of thin people, you at least have 2 centimeters to give. So you should really feel a fair amount of appropriate guided confidence on how deep you can and cannot bury the scalpel, right? Make sure you follow right alongside the guide wire. It's a myth that you can shear the guide wire with your scalpel, right? Never say never, but there are 3 spring-loaded guide wire cores that are actually intertwined and combed into one. So it's really, really difficult. And is it impossible? No, I'm sure there's some weird video on some YouTube somewhere that has that, but go right next to it because you don't want to create a skin tag, all right? So once you've created a nick, I actually do that. I take your guide wire and sort of lift it up, right? So you see that there's a clear disruption of the skin and that there is no skin tag. If you find a skin tag, then repair it, of course, cut it through and make sure that you have an adequate nick. Okay, put your scalpel down, secure it, grab your dilator, feed it through. And here's another thing. Now, remember when we access the blood vessel, we're at a fairly acute angle. When we passed the guide wire, we went down. For the dilator, you want to emulate the introducer needle angle again, okay? And it's sort of one smooth forward twisty motion, just like that, all right? And you don't need to bury it, right? You just want to feel that give, because what you're trying to get through is really that SCM, right? Once you feel that give, don't pull it all the way out. Once you feel that give, advance your guide wire about 3 to 4 centimeters and feel it move smoothly and nicely within your dilator. That is very important, okay? Once you feel that, you pull the guide wire out. You pull the dilator out, pardon me, and you take your central line. You make sure that only the brown port is unlocked. And of course, you flush the entire central line. Prior to this, pass your guide wire all the way back. Once you have it on the other end, you advance this triple lumen. And this is where there are a couple of different thoughts, right? There is the 16, 18, 20 rule, which is 16 is the right subclavian, 18 is the right IJ, 20 is the left IJ. Honestly, I think those were rules made before the era of ultrasound, and we're all gangsters, right? You know how far you should and shouldn't put in a central line. And what I generally do is, till there's a reason otherwise, I actually do bury the central line all the way to the hub. If for some reason you have a portion of your central line sticking out, there are those extra skin securement tacks in your central line kit, right? We're not going to spend a lot of time going through this. It's pretty simple. There's a portion that goes directly over the central line, and then there's a portion that goes over that cap. But make sure you suture both in your central line and those caps if you actually do end up using it. Okay, and once your line is in, make sure each port pulls and flushes. And if for some reason you encounter any resistance, there's sluggish flow, you can't withdraw, don't push it, right? Just leave it where it is, don't use the line, and you need to get an X-ray to confirm where it is. Okay, now let's say you do have all three ports pull and flush. I generally at this time take my ultrasound probe and hand it to another provider at the bedside. And while the operator is still sterile and has some saline, I take one of these syringes, agitate it. Yep. And once the person is able to do a parasternal long axis or a subxiphoid view, just inject some saline. And if you have agitated saline that you can visualize in the RA or RV, there you go. You have successful placement of a venous central line. Want to hear another ninja trick about how deep to bury your central line? You know that guide wire? When you advance that guide wire, have someone give the ultrasound probe at that point. Have someone take a subxiphoid view, and if you visualize the guide wire, pull it back till the person can't see it. Take a measure of how deep that wire is buried, and put the central line in exactly to that point. And tell me then that your central line is not at your RA-SVC junction. So in recap, the perfect central line is really a lot of good behaviors done very, very quickly, very, very efficiently, all done the same way every time. Take home points: when you access the vessel, it's a very acute angle. When you're putting the guide wire, you've got to drop the angle, right? When you pass the guide wire, make sure that you have actually straightened out the J-loop before. People tend to throw away that protective sleeve on the J-tip. Don't do that, all right? And then when you are sure that your wire is into about a good 20, 25 centimeters, make sure you confirm the existence of the wire before you dilate in two planes, short axis and long axis, right? Once that is done, you dilate, make sure there's not a skin tag, know how to appropriately and judiciously wield your scalpel. And once your dilator is in, you only need to go in as far as you feel that give. And once the give is in, make sure your wire moves up and down smoothly. Take the dilator out, put the central line over it, and if you're skilled enough, I dare you, I behoove you to use the RA-SVC junction skill. Let's move on.